Hi, I'm Carrie, a stroke survivor and a member of Bind.
Hi, and I'm Brittany. I'm a brain injury survivor and a member of Bind. Today, our guest today is Dr. Sasha Blaskovich, or Dr. B, as many patients like to say. Is a board certified chiropractic doctor who specializes in assessing and treating head and neck injuries. After playing football for over a decade and working with injured patients for over 20 years, Dr. Blaskovich has devoted his career to helping people going through similar problems as he has gone through with his head and neck, and has focused his continued education in injuries for more than 20 years.
Opinions shared by the guests of the show are their own and do not necessarily represent the views of the host, Bindwaves, or the Brain Injury Network. This podcast is for informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of a healthcare provider with any questions you may have regarding a medical condition. Thank you.
So, to get us started, tell us a little bit about yourself and how you became interested in being a chiropractor and what inspired you to join this field.
Well, initially, the reason I wanted to become a chiropractor was because of a hip issue I was having as a 12-year-old or 9-year-old playing soccer for several years, where my leg would go numb when I would run around. But other than that, I was the strongest, tallest kid on the team. But it was just that pounding that would just shut something down where my leg would go numb. And so it was a chiropractor back at that time that my dad was seeing for a herniated disc, who offered to have a look at me because my dad was telling him about me. And he basically said, you've got a 19 millimeter leg length difference. Your spine is out and I need to do a few adjustments, give you a heel lift. And at that point in time, I was going from doctor to doctor for about 2 years, all telling my parents that I wasn't strong enough and my body just wasn't able to handle sports and I should stop playing sports. And then this chiropractor literally fixed me in a span of 6 weeks with a heel lift and a few adjustments. And I was sold. I wanted to do what he did. He was excited about what he did. He loved talking about his patient success stories. It was super exciting. And then I had decided at the age of 12 I wanted to be a chiropractor, not knowing that the reason I would be, or the way I would be practicing chiropractic would have nothing to do with, hips and leg length differences, but with, misdiagnosed concussions, or misdiagnosed upper cervical ligament injuries masquerading as concussion diagnoses. And so that's what brings us to today is basically, I devoted my career after finally figuring out what was wrong with me after a football injury in university, which I never would have been playing, had my parents listened to these doctors telling them that I shouldn't play sports anymore. So maybe they should have listened. But anyways, the chiropractor did fix me from that and got me in a direction where I wanted to do what he did. Only lo and behold to, finish chiropractic school several years after this injury and have the knowledge, the basis and the ability to go and learn things about this problem that I have that the average person in the public wouldn't know where to start. And the average doctor in society can't be bothered trying to learn about it because they're busy enough and focused enough on what they're doing, assuming that this is such a rare and obscure thing that I had. Well, it turns out that it's actually extremely common to some varying degree of severity, where the person has injuries or an injury that results in damaged ligaments in the upper cervical spine or upper neck, rendering that region too mobile, whether it's hypermobile or unstable. Both are different variations of too much mobility. And that excessive mobility then puts pressure repeatedly on the brainstem, causing someone like myself or other people, and again, it's very, very common to have some level of concussive-like symptoms persistently for either many years or the rest of their life that go undiagnosed. And sometimes it's progressive. And oftentimes these patients find me either by word of mouth or online support groups or what have you. And lo and behold, they have very similar injuries to what I had or what I still have that were undiagnosed. And the diagnosis helps them gain direction and gain a sort of a sense of purpose and path to getting some benefit or some improvement to this so-called lifelong sentence.
Okay, so now I'm going to ask you a question. This isn't exactly the question I had. I'm going to come back to that one, but so I mean, we're brain injured. I mean, I was a stroke survivor, so obviously I didn't have anything to do with that kind of stuff. I see a chiropractor for other issues. But yeah, but so you're not saying that necessarily like the issues that you're talking about, like you had, that wasn't caused from a brain injury, or was it caused from concussions that were just undiagnosed? I guess that's what I'm trying to understand better.
That's a very deep question, because ultimately, and I've talked about this on many podcasts, how the upper cervical instability, which then results in repeated malpositioning of the bones, um, and it's persistent, causing, basically in a really simplified fashion, the drainage tube that's inside the spinal cord and brainstem to be slightly kinked. And when that brainstem drainage portion gets slightly kinked, the amount of fluid that the brain is making, which has to equal the amount that is draining through that upper neck, is no longer equal. So there's less draining in a tiny fraction than that's being produced. So every time that there's a drainage moment, there's a little bit that back pools. And so
Okay.
that little bit that back pools then stays stuck inside the brain and inside the skull, eventually causing a mild expansion, if you will, of that fluid cavern where it's being produced. And then that does compress brain tissue, resulting in brain related symptoms. But the true origin of that expanding pressure, and it's not a constant thing, it fluxes with relation to the unstable positioning of that upper neck. Then the person gets diagnosed with a brain related problem, but the actual origin of that distension or that pressure increase isn't actually coming from the brain. It's coming because of the upper neck having that glitch, reducing the amount of drainage that then causes back pooling, and then you get brain compression, mild compression, and it can cause tons of things like visual changes, cognition, memory loss, brain fog, and just a constant pressure inside the brain, just like feeling like you're constantly having a mild flu. And those are sort of the simplest symptoms that people generally will portray having that. And unfortunately, when the MRI is done of their brain, there isn't a massive or a gross amount of fluid accumulation that is perceived by the radiologist. So it gets reported on as normal or unremarkable. But when you've seen thousands of these scans, you can see what a person's scan looks like of the brain where they don't have that accumulation. And then you can also see the subtle difference with somebody who does have that mild accumulation, which likely has bearing on their symptoms. But, when I discuss that with radiologists or neurologists or neurosurgeons, in their opinion, these are normal variants and non-entities for that person. But I humbly disagree with that.
Sure.
Yeah.
That kind of makes sense. So yeah.
That kind of happened to me. So yeah, because my brain injury was from a car accident, and so I broke like my airbags didn't deploy, and then I broke my seat with my head, and I blacked out. So it was like really hard. And then I went to my neurologist, and he's like, "Okay, go home, turn off the light." So I did. I went back to school, which was 2 hour drive. So, but at the hospital after accident, they're like, "Oh, you have herniated disc in your C4, C5," and so then later it's like post concussion. So mine was a cat and mouse game, but I still have problems. Like my hands go numb each time, and then I get cricks in my neck all the time. But yeah.
Yeah. So the mid neck is always the whiplash component that is recognized, I guess. Whereas when you get to the upper neck, the momentum of the 12-pound head, being decelerated or accelerated, having to be somehow decelerated or slowed down by something. And when the event happens that a person, for example, isn't braced for, then this 12-pound head has so much momentum that can only be slowed down, because there's no bracing or no guarding, muscular guarding, by ligaments. And those ligaments will fail to some degree, whether they fully tear or they just stretch a bunch of fibers. No matter how you dice it or slice it, you end up with too much mobility after that. And that too much mobility isn't actually a good thing. So this whole notion that a person has a great range of motion, that might sometimes be pathologic.
Interesting.
So other than like automobiles, what else caused whiplash?
Sorry, say that again.
So what other causes of whiplash instead of automobiles? Like, is there any other causes that causes
Yeah,
whiplash?
bar fights, slip and falls, skiing, horseback riding, soccer, any kind of contact sport. So football is probably one of the most common ones, and then soccer probably follows that, and hockey, ice hockey. So there's no shortage of examples, I guess, in the professional leagues of people getting quote unquote concussed. But when you look at the game footage or the film footage of that moment where they got so-called their head bashed, there's a lot of cases where there isn't a massive head impact, but there is impact that causes a forceful rotation of the neck. And so that rotation component is what damages these upper neck ligaments, because the main amount of rotation in the head, or the neck, sorry, comes between C1 and C2, the top two bones. And so when you have a forceful rotation of that area, you will have a predisposition to damaging ligaments, which then puts you into the same cascade, like I explained, of repeated and persistent misalignment, causing sort of the drainage channel to be reduced somewhat, causing the backflow into the brain, causing then the brain-like symptoms, which we get labeled with post-concussive syndrome.
Sure. So when you just said that, in my I'm a hockey fan, so in my brain I'm thinking, in hockey fights or like boxing, that moment you see the lights go out in that person, and you're like, oh, he was knocked out. He's knocked out. That's that moment of whiplash. I mean, maybe can you? I mean, we all think we know what whiplash is. Maybe give us the textbook definition of whiplash, just for our
Well,
listeners.
whiplash, yeah. So whiplash is a mechanism of motion. It's not an actual injury. So to diagnose somebody with a whiplash injury, it's technically incorrect.
Okay.
So whiplash is an acceleration deceleration phenomenon that is the motions that the head and neck go through. So that's what whiplash actually is. And then the true diagnosis, if you were to really dissect it medically and scientifically, would be, the person sustained a whiplash event, and they sustained then either grade 1, grade 2, grade 3 sprains of whatever ligament you can properly name, or whatever ligaments you can properly name. And in order to name those ligaments, you have to do motion x-ray or video fluoroscopy x-ray of the person's neck in motion, so that you can see which segments, for example, are sliding inappropriately or gapping inappropriately compared to their neighbors. And then by measuring those amounts, you can determine then that, the degree of severity of the damage to the ligament, but more importantly, that the ligament is compromised, because it's supposed to restrict that motion. And if you see an excess motion, then you can say this person had a whiplash and they sustained a C4-5 anterior longitudinal ligament sprain grade 2. And so what that means is that person is going to have too much movement at C4-5 in the backwards plane, and they might have it in the forwards with the posterior longitudinal ligament as well, in which case you can almost guarantee, or you can guarantee, that within 7, 10, 12, 15 years, that person will have degenerative arthritis at C4-5. And so C4-5, C5-6, probably in the reverse order. So 5-6 and then 4-5 are by and far the most common areas in the cervical spine where you see degenerative changes in the average person, in addition to the fact that their normal curvature, which is supposed to be concave in the back, is either straightened or reversed. And then that causes abnormal mechanics in that region of the spine. Plus, to add fuel to the fire, you have excessive motion, excessive friction, and excessive wearing down or breaking down of the disc or the cartilage in between. And then, like I said, 7, 10, 12 years later, you do an x-ray and you're like, oh, this person has degenerative arthritis. Well, I've even seen that degenerative arthritis in somebody who's 23 years old who sustained one of these injuries when they were 12.
Sure.
And so a 23-year-old shouldn't have degenerative arthritis at C5-6. That's something you technically expect to see in somebody who's 55, 65, 70 years old due to normal wear and tear, which I don't believe exists. But seeing it in somebody young and then listening to their history or dissecting their history, there is an event that led to that. And like I said, it takes, 7, 10, 12, 15 years to finally develop into degenerative arthritis, which is visible on an x-ray, but it absolutely is linked to that event.
Okay. And that all makes sense. So, but just because you have one of these cervical spine injuries, or even a whiplash event, we'll just say. Doesn't necessarily, I mean, I'm not a doctor. I just pretend to
I've
know what
thrown
I'm
a twist into your perception of
I
what
know.
things are.
No, you haven't. It's good. That's the whole point we do this, is so that we can better understand. But you can have this cervical damage. That doesn't necessarily mean you ended up with a brain injury. I mean, now we do know concussion equals brain injury, or most likely some level of.
It influences the brain, yeah. So I think a strong delineation between a true brain injury, which you can actually then see on scans, and there are scans that can highlight or make hot spots on the brain tissue to say that there's a metabolic change and therefore the brain was injured. But when that's all done and you don't see anything, then the influence that is being perceived as brain-like related has to be coming from somewhere else. And so this subtle accumulation of increased fluid causing increased intracranial pressure, resulting in compressive forces on brain tissue and neurons, which will then start either glitching or hyperfiring or doing something that they're not supposed to, is happening. So it's not directly a brain injury, but it's an injury to that region that has an influence or an impact on the brain mechanically. And I do believe long term with people that are like that or that have that scenario, and again, depending on the severity of that scenario, likely leads to some form of chronic degenerative disorder that we've given names to, such as dementia, Alzheimer's, ALS, MS, Parkinson's. I believe those are all somehow directly linked to this phenomenon long term. So if someone's had this for decades and it's been undiagnosed and potentially they've been doing all the wrong treatments for it, sort of perpetuating the instability, if you will, they're predisposed to acquiring one of those conditions later on.
Okay.
All right. So we also talked about like the conditions and your brain being hurt also cause brain fog. So how does the cervical spine play a role in the occurrence of brain fog, like headaches and dizziness? And what exactly is brain fog?
I think brain fog is just a term that people have given to just not feeling clear in their decision making, in their perceiving, in their vision, in their hearing, just in how they feel balance and coordination wise, that there's just something that's sluggish and not sort of clear and firing on all cylinders as they perceive that it should, or as they recall that it used to before they had these injuries, where they could just, without any effort, have things fall into place and be able to multitask and be able to concentrate on a task and be able to, be distracted from that task and then quickly get back to it and not, lose their train of thought. Those are basically sort of the phenomena that would be diagnosed or defined by people as brain fog. And the cervical spine, so that back pooling, literally, I tie back to that, would be probably the main causator. And then when you talk about headaches, that increased pressure is a version or a means by which the increased pressure can be perceived as pain by somebody, so AKA headache. But more importantly, the little intrinsic muscles or the deepest muscles in the upper neck that would be trying to then stabilize the unstable upper spine when the ligaments have been damaged, they all have an intricate connection to the brainstem and brain coverings and the spinal cord coverings called the dura mater. So that's the outermost covering of the spinal cord, brainstem, and brain. And these muscles actually have myodural bridges, which are basically muscle to dura connections that are intended to actually be there to make sure that the dura never folds back in against the brainstem or spinal cord, that it's always kept clear of contacting the brainstem and spinal cord. Excuse me. But when these muscles get really, really tight while they're trying to fight and hold this instability together, those myodural bridges get more tension put on them. So you get a dural headache because of the myodural bridge being hypertensed. And then by releasing the muscles with just acupressure, you can release the tension on the muscle, release the tension on the myodural bridge, release the tension on the dura, and reduce the headache. And the key feature or factor there is when you're pressing on those muscles, they should trigger a referral into the headache spot. Like say a person's feeling a forehead headache or headache behind their eyes or a temple headache. When you press on these muscles up here, there will likely be a trigger point referral either going to the forehead, going behind the eyes, or to the temple, actually making that headache that they're already perceiving feel worse. And when you then release that muscle, and that trigger point, and it eases off, then the actual background headache is less. So they will actually have a reduction in the headache. But initially, to treat it, you find the trigger point in the neck that refers to their headache spot, and you pulverize it basically, causing during the treatment sort of an accentuation of the headache. But then after you're done, the baseline headache will drop. That's probably the most common, whether we call that a muscle tension headache or a cervicogenic headache or a dural headache. They all are basically one and the same, and they all also resemble migraines with, flashes before your eyes, dark spots. So people often get diagnosed with migraines, and all sorts of migraine type protocols are, initiated, sometimes with success, but I would say more often than not with no success. And that's because it's not a vascular headache, it's an actual mechanical muscle and myodural bridge and dural headache.
Okay, so what would you say maybe are like some more common symptoms for someone to look at? Because like we know if you get a splitting headache like you've never gotten before, that the world's about to come to end, that it could very well be an aneurysm about to burst, and it's get to the hospital. I have constant headaches, or what maybe is that one symptom that you would say, okay, this is where you need to say, I need to maybe take a different look and see if it's something with my alignment, as opposed to, I've been there, I've gotten an MRI, I don't have an aneurysm, I don't have this. But in migraines, it's not really a migraine, but it's definitely kind of concerning. I keep having a headache. What kind of symptoms would you look for, or say where you would know to go, okay, maybe I should go ask a chiropractor about this?
Yeah, and I would say not every chiropractor is proficient in this. I would seek out an upper cervical chiropractor personally, who focuses on the Atlas region. But just headaches alone are rare in this patient demographic. So maybe with a brain injury, it is just a headache. But the patients that I see, and myself included, the flux of symptoms usually includes either blurry vision, double vision, ringing in the ears, fullness in the ears, like a constant sinus pressure or postnasal drip, hoarseness of the voice, heart palpitations, like basically the heart racing, breathing difficulties, urinary urgency, constipation, diarrhea, balance and coordination issues, fine motor, like they feel like they're kind of vibrating a little bit.
Yeah.
So those are all brainstem related components that if a person is experiencing those, and not just a headache, but a headache as well, potentially, then the likelihood that the upper neck is involved in everything that they're experiencing is really high, really, really high. And then, like I said, seeking out an upper cervical chiropractor who can possibly triangulate by x-ray to say, okay, your C1 is malpositioned in so many degrees tilt and so many degrees rotation, and we're going to make an attempt at aligning that, is absolutely, a very critical thing to try. And in the cases where a patient has done that, and repeatedly that is done and potentially gives them some short-lived benefit, but very quickly recurs, in which case, the chiropractor would say this, your adjustments are not holding, then my suspicion would strongly rise to say, okay, there's possibly ligament damage up there, which would be a logical reason as to why it's not holding, and that person should then logically undergo a motion x-ray to see if they indeed do have an unstable upper cervical spine, which will then explain everything. And there are very few motion x-rays out there to diagnose this, but it is the gold standard for diagnosing excess motion in the cervical spine.
So, what form of treatment have you pursued?
Myself?
Just in general for the symptoms that you see in patients?
Like for the upper cervical instability?
Yes. Mm-hmm.
Yeah, so there are three basic sort of categories, least invasive to most invasive. So the least invasive would be basically the ischemic compression or the acupressure or the sustained pressure on the selective muscles in the upper cervical spine, and sometimes the jaw or the chewing muscles or the clenching muscles. And then that's basically going to give a temporary reset to those muscles and make them functional for a period of time. They will tighten up again because they're not the problem. They're responding to the problem, because the problem is damaged ligaments resulting in excessive movement of the bones, which those muscles then try to mitigate. So releasing those muscles repeatedly, which is basically what I've been doing for the last 24 years, is very effective. But the repetitive nature of having to do that is not something that everybody is willing to grasp or accept. And so the next step beyond that would be some kind of a regenerative therapy, which would be interventional medicine. So either platelet-rich plasma or stem cell injections, which then always require the motion X-ray as an evidentiary diagnostic modality to show where there is excessive motion, so that the doctors that inject the platelet-rich plasma or the stem cells know exactly where to go, so they're not blindly just doing it everywhere and hoping for the best. And then if that is not successful enough for the individual who's dealing with these problems, then the last-ditch effort is basically fusion surgery, where the C1 and C2 are basically fused together surgically, in which case the instability becomes completely immobile, which means there's no longer any brainstem irritation by C1 and C2. And I guess there is a fourth option, is just to, learn to live with it and accept the fact that you're going to repeatedly have that, which is unfortunately what most people are in, who eventually discover then this acupressure or the stem cells and PRP or the surgical options. But sometimes they're searching for, decades before they get to that point. And thankfully with the internet, people are in chat groups and support groups where they're exposed to these concepts. And I think that expedites their, getting to that point much faster than hoping that their medical doctors or neurologists or whatever doctor they're seeing is going to guide them in that direction, because they won't.
No, I think that's great. I'm so glad that we had you on today, Dr. B, because this, again, like you said, this is not the normal information that people seek out when they go to a chiropractor, but it definitely makes a lot of sense to me what you're saying. And so I'm glad that we had you on. We appreciate you taking the time out, and I hope you have a safe drive the rest of the way to Seattle today. But thanks for coming on.
Appreciate it.
Until next time.
Until next time.
We hope you've enjoyed listening to Bindwaves and continue to support Brain Injury Network and our nonprofit mission. We support brain injury survivors as they reconnect into life, the community, and the workplace. And we couldn't do that without great listeners like you. We appreciate each and every one of you. Please remember to click the like button, the share button, and the subscribe button on YouTube. And follow us on Instagram at Bindwaves and Brain Injury Network on Facebook. You can email us at bindwaves@thebind.org or go to our website, bindwaves.org, or call us at 972-769-2463. Please continue watching. Until next time.